Okay, thank you so much, Matt. I'm happy to welcome everyone to our university seminar series. Today we will be our seminar series is Europe and COVID, and the idea behind our series is to look at how various countries, various populations are addressing the COVID crisis in a bunch of different ways. So the kind of logic behind today's event was precipitated back in the spring as we were watching what was going on with COVID in France in particular. And what happened then was on April 1st, 2020, Jean-Paul Mirat, who is the chief of a major Parisian hospital's ICU team, suggested in a media interview that a potential COVID vaccine could be tested in Africa. And he said, this is a quote, where there are no masks, no treatments, and no ICUs. Also present in the interview was Camille Locht, the director of France's National Medical Research Agency, who agreed with the statement and, without saying so directly, nevertheless indicated that such a research plan was already under consideration. Needless to say, public reaction to these statements were swift, with French anti-racism association SOS Racisme releasing a statement that, quote, Africans are not guinea pigs, and Moroccan lawyers threatening lawsuits for racial slander. While the medical experts subsequently apologized and the media network blamed poor editing in the interview, the debate raised by these comments touches on long and complex histories of medical experimentation and testing in Africa, particularly during the French colonial era. So that's what led us to this event, which brings together leading historians of French colonial public health policy to explore the social and scientific history of French vaccine research and testing in Africa and its implications for current vaccine developments today. So each speaker will give brief introductory remarks, and then I will ask a few questions to foster a conversation, and then we'll have time for discussion. We decided that we would have Professor Valmet, Aro Valmet, speak first based on chronological order of the material focused on. So I'll introduce him first, let him speak, and then I'll introduce Professor Jessica Pearson, who will speak second. So Aro Valmet is a historian of modern Europe at the University of Southern California, with a particular interest in the intersection of technological change and forms of governance, claims about humanitarian development and global modeling. Dr. Valmet's first book, which you'll see in a second, Pasteur's Empire, Bacteriology and Politics in France, Its Colonies and the World, looks at how bacteriological research in the early 20th century came to represent France's civilizing mission in its colonies and shaped politics in the French Empire in fields ranging from labor rights to industrial policy. Dr. Valmet is currently working on the history of cybernetics, data processing, and global development from an Eastern European perspective, and he maintains an interest in public outreach. He is an editor of the Estonian cultural monthly Vikakar, a member of the Eurozine network of European cultural journals. Also, in 2019 to 2020, he was a fellow at the Democracy Project at the Respublika Foundation in Poland. The title of his talk today is Infrastructure and Vaccine Politics, Lessons from the Yellow Fever Campaigns in West Africa. So with that, I am honored to pass the mic, figuratively, to Professor Valmet, who is joining us today.
Thank you, Kathryn, and thank you to you and to Matt for putting this panel together. It's so great to see you, and it's great to see Jess. The one thing that Kathryn didn't mention is that we all did our PhDs at the same institution at New York University. So it's really, among other things, a meeting of old friends. I'm really happy to be here. Watching, first of all, let me see if I can share my slideshow here, because I have a couple of images that I think will be instructive. And I'm going to try to keep my remarks to, Matthew said 20 to 30 minutes, I think. So I'm going to try to keep to that. Watching this pandemic unfold over the spring and the summer was, to me, as a historian of science and medicine, a really bizarre experience. Because I've been studying epidemics and the politics of public health for a while now. So this experience of lockdown, of watching the debates unfold publicly, reading reports from Le Monde or the Washington Post about what's going on behind closed doors, really reminded me of a lot of archival sources I've seen in my own research into the politics of public health in colonial French Africa. And it really made me appreciate, and it really gave me a greater level of historical empathy for the actors that I was studying, because you could really feel the anxiety and the immense amount of uncertainty within which people had to make decisions with very big consequences. And at first I tried to kind of resist this urge to draw parallels between what I had studied in about colonial French Africa and what was happening in France and Europe around the world, because, as historians, we're trained to resist that kind of impulse. We are trained to see the particular in events, to see what is unique about a particular development in the 1930s or, in the 2010s. But, after a while, I thought, okay, well, there is the saying that history doesn't repeat itself, but it does rhyme. And looking at the 1930s and the 1920s, from the perspective of being in the middle of this pandemic, I think can throw into sharper relief some patterns that are fairly common to public health crises. For reasons that involve continuities with the early 20th century and today, but also for reasons that I think are more universal. So one of the things I want to do in these following remarks is to sort of use the case study of the yellow fever epidemic in French West Africa that took place in 1927, 1928, and then the following project of developing a vaccine for yellow fever that was led by the Pasteur Institute, which I'm sure many of you have heard about in the context of this current crisis, as a way to think through some more general issues that pertain to the current crisis today. So in order to do that, I'm basically going to draw on two sources, and one of them is my own research, which, if you're interested, you can read more about in the book, Pasteur's Empire, Bacteriology, Politics in France, Its Colonies, and the World. And then this very recent study that just came out a couple of weeks ago, and as Jess told me before the beginning of the session, was just written about today in Le Monde. This study by 4 sociologists called COVID-19, une crise organisationnelle. So I'm going to draw some parallels, but I'm going to mostly focus on French West Africa. So the place where I would like to begin, well, first of all, I'm going to focus on 3 themes, basically, that we can see in the yellow fever epidemic of the 1920s, and that I think we see repeated in a slightly different form today. And these 3 themes are, first of all, preparing for the wrong emergency, this initial failure of public institutions and public health institutions to respond in time and to respond adequately. I know I want to explore a little bit of why that is. And then following from that, the tendency to choose solutions that focus on these technological miracle cures or miracle fixes, such as the potential of a vaccine over kind of shoe leather public health infrastructure. And then finally, speaking directly about vaccination and vaccine testing and vaccine deployment, I want to talk about how infrastructure creates invisibility, because it turns out, something that I think you start thinking about it is kind of obvious, that that there is really no antagonism or opposition between the development of public health infrastructure and vaccination. Vaccination depends on that infrastructure as much as any other public health intervention. And if we lose track of that, then we can miss some pretty serious things. Okay, so now I want to go back to Dakar, the capital of Senegal, and at the time the capital of French West Africa in 1928. And what you're seeing here is a photo from 1928 taken on the Dakar Plateau, the kind of French district of Dakar, with these two men standing in front of a monument to the yellow fever epidemic of 1878, which was historically destructive in Dakar when it took place. It killed almost every single European doctor in the city. It was disastrous for the European population of Dakar. But also crucially, by 1928, 50 years had passed since that yellow fever epidemic had occurred. There had really been no outbreaks of yellow fever, not just in Dakar, but around the region during that period. And a lot of stuff can happen in 50 years. In 50 years, an entirely new science can develop that changes the face of public health and Western biomedicine, the science of bacteriology. In 50 years, a war can happen, the Great War, World War I, which impacted French West Africa in quite a number of ways. And in 50 years, a pandemic can happen, because a little while after the 1978 yellow fever epidemic, Senegal, like many other places around the world, was hit by the third Great Plague pandemic, which began in the late 1880s, early 1890s in China, in India, and then via largely commercial routes spread quickly to places such as Porto, San Francisco, Rio de Janeiro, but also Dakar. So the events that really shaped Dakar's public health policies in the early 20th century were plague outbreaks, and Myron Eschenberg has written quite substantially about them. The biggest one took place just as World War I was starting in 1914, and there were several other smaller outbreaks in the following years, sort of going through the 1920s. And these are really the events that shape how officials in Dakar respond to these kinds of emergencies. And their responses are shaped by a number of different factors. The first is a kind of racially divergent response, where public health authorities in Dakar focus on the surveillance of Europeans. So they're very interested in who falls ill, for what reason, the kind of what we would today call tracking and tracing, right? Who gets the plague? In which areas of Dakar are these outbreaks concentrated? They're interested in the movement of rats, because rats, of course, are the carriers, the animal vectors of the disease. But when it comes to applying containment policies, then those are really focused on the African parts of the city. So when sanitary cordons are imposed, when disinfection crews are sent out, and when curfews are imposed, and those are disproportionately put on the African population of the city. And there are a number of ways how the public health authorities argue that this makes sense. And a lot of this has to do with this idea of hygienic modernity, that Europeans in general are capable of maintaining good hygienic practices, that European houses are better built and therefore better capable of keeping out rats. And finally, this understanding, or rather this prejudice, that African populations do not respond to sort of a gentle and quiet calls to follow the laws of to follow the rules of hygiene, but instead they have to be those rules have to be imposed by the military. Another aspect is that these activities have a performative dimension to them. Epidemic outbreaks are generate a lot of anxiety and in particular generate a lot of expectations on behalf of various parts of Dakar's population. We see merchants, we see military officers, we see both Europeans and African elites write and organize protests and demonstrations, all calling for some kind of public response. So there's a real demand for something that is flashy and aggressive. The government believes that that the best way to demonstrate that is to demonstrate that on Africans. So some of the consequences of these plague outbreaks, for instance, are the segregation of African and European populations in Dakar, because over the course of these outbreaks, one of the responses of Dakar's public health authorities is burning down European housing. Burning down African housing, which is considered to be too cheaply built and too insalubrious to properly disinfect. And as a result, the city becomes ever more segregated. And as these epidemics come up and as these responses kind of repeat themselves, it creates a conviction in the local government that this is exactly the appropriate way to go about things, because it seems that every subsequent epidemic has become smaller, more easier to contain, and so on and so forth. So in 1919, the Governor General of French West Africa, Martial Merlin, writes that the segregation, the absolute separation of native and European quarters, will remain an absolute necessity. Now, this all is thrown upside down with the yellow fever epidemic of 1927, which begins not in Dakar, but in a surrounding village, in the village of Thiès, and then in sort of early spring of 1927, and then by the summer of 1927, we have first outbreaks in Dakar. And it takes the Dakarois government until October of 1927 to actually respond with some kind of active measures, which end up being curfews and sanitary cordons. They are initially very resistant to imposing any kinds of measures on the city at all. One of the reasons is that they believe from these previous plague epidemics that that they have sort of a handle on imposing on handling epidemic disease. The plague epidemics, after all, have gotten much less destructive. And once they do impose curfews and sanitary cordons, they again disproportionately target African areas. But here's the thing. Yellow fever and the plague are two very different diseases for a wide variety of reasons, right? Like yellow fever is is transmitted by the Aedes aegypti mosquito. They're, one is a bacterial disease, the other is a viral disease. But for the purposes of this situation, one of the major differences is that in some sense, the plague does impact African populations more, because it is actually the case that European housing is more difficult to penetrate by rats. So they are, in some sense, safer. The thing with yellow fever is that yellow fever, when it is contracted in childhood, tends to produce a relatively mild form of the disease, and then you're left with lasting immunity. And in that sense, it's sort of like the measles. Whereas if you don't have previous exposure to yellow fever, it can really hit you very hard. It can be really destructive. And what this means is that, by and large, the African population of Dakar is not hit that particularly hard, whereas Europeans, who are often, only in Dakar for a couple of years, they're on a tour of duty, or they're here for business, or they've been sent on an administrative post, are hit very, very hard. So out of 80 cases of yellow fever that are registered in Dakar in the fall of 1927, some 50 end up being fatal. And different actors notice this. And in particular, this is noticed by Blaise Diagne, who is the Senegalese African deputy to the National Assembly in France. And Blaise Diagne makes a big deal out of this. He ends up writing to the National Assembly. He ends up giving interviews in France, where he makes precisely that point, that what he is seeing unfolding in Dakar is that indigenous districts, and I'm quoting him here, which have been properly surveyed and where inhabitants have had to submit to the rules of hygiene, have been spared from the disease. By contrast, Europeans live in houses that are often defective but inviolable. And I can say without fear of contradiction that all recorded cases of yellow fever have been recorded in European parts of Dakar. So he is now directly accusing essentially Europeans for not following their own hygienic guidelines, saying that, look, we are not the hygienically deficient ones, you are. And this really puts the government general in a bind, because they are now faced with a number of competing constituencies who are either demanding action or demanding different kind of action, and they're really at a loss at what to do. Now, here we come to the second problem. Okay, so what is the solution of the government general to this political situation that they've created by responding to a yellow fever outbreak as if they were responding to the plague? Now, it turns out that one of the problems with these sort of shoe leather public health measures that involve curfews, that involve sanitary passports, that involve this, in the case of mosquito-borne diseases, disinfections, putting out mosquito nets, things like that, is that they are both very costly in the sense that they cost a lot of money, they need a lot of manpower, but they're also very costly, as we've all learned over the past couple of months, in that they restrict the activities of various different constituents. They make commerce more difficult. They make people angry that their particular neighborhood is being targeted as opposed to some other neighborhood. And the government general of Dakar learns this the hard way as they start trying to impose the same containment measures they've been imposing on Africans now on European and other basically non-subject populations. As they try to limit movement in and out of Dakar, they start, getting letters from local businessmen and Syrian traders of Syrian origin, of Middle Eastern origin in particular, who are complaining, one, that they are being mistreated by police authorities, that they are called, they are being addressed in imperious and arrogant tones, and that they are not allowed to go out into the countryside to buy various kinds of agricultural products that they are then planning to export. European travelers and military stationed in Dakar are starting to ask for repatriation. They start writing to their superiors and to the National Assembly in France, demanding that they be allowed to leave the city. And then finally, of course, you have Blaise Diagne, who is suggesting that all of this is showing how misguided the French had been in assuming that Africans were hygienically deficient in the first place. Now, one way the government general thinks they can get out of this is by going to the local bacteriological laboratory, by going to the Pasteur Institute of Dakar and asking, listen, would you guys come in and act as a neutral party, because it is clear that the political and regular public health authorities have lost all confidence in this situation, have lost all trust of the population. And ideally, this would take the form of something like a vaccination program, because this is something that is widely accepted by this point, because in places like Dakar, everybody has experience with smallpox vaccination, and it's a program that doesn't require from us those kinds of impositions on powerful constituencies that curfews and quarantines would do. And the Pasteur Institute is happy to oblige. They invite their the Maison Mère, their sort of headquarters in Paris, to the task, and a bacteriologist named Jean Legret, who you can see portrayed here, looking into a microscope on the left as African lab assistants look into the camera in this image that I find to be just totally fascinating, comes to Dakar to start work on this vaccine project. Here's another image of Jean Legret. So here, this invitation by the government general to the Pasteur Institute had, beyond all the humanitarian goals it had in mind, it also carried a very clear political goal, which was to calm things down, to divert the attention of Africans, of Syrian traders, of Europeans, and so on, to something that everybody would be able to accept, that would not create these cleavages that quarantines and sanitary cordons were creating. Now, one of the ways that this is the 1920s and 1930s we're talking about, not the 2010s, is how long the vaccine project takes. Because the epidemic happens in 1927. It really isn't until 1938 or 1939 that we have that the Pasteur Institute has the first vaccine that it feels comfortable testing out on thousands of people, what we would today call phase 3 trials. So we really have come a long way when we're talking about getting a vaccine in 10 months or a year, as opposed to 10 years or even longer than that. And here I come to, and this is the Institute, the Pasteur Institute of Paris, which leads this whole project. And now I come to the third theme of my remarks, which is infrastructural invisibility that can occlude some of the adverse side effects of mass vaccination programs that can make it actually more difficult to understand whether the vaccine is working as intended, what kinds of adverse consequences it has, and so on and so forth. So now we're in 1939, and Legret and his team are pretty much preparing to roll out a mass vaccination program in French West Africa. Their goal is to vaccinate 14 million people over the course of 4 or 5 years. And the remarkable thing about their program is that they actually managed to get it done by the end of whilst World War II is going on around them. By 1945, they claim that the entire population of French West Africa has been vaccinated. Now, one of the interesting things about this vaccination program is that as Legret is going into this, he has some reservations about the vaccine. In small-scale clinical trials that have been held in Tunis, in North Africa, and in Paris, in metropolitan France, Legret has observed some cases of serious neurotropic effects, adverse effects that are caused by the vaccine. So people develop very high fevers, meningoencephalitis, and there's one sort of very a high-profile case of a woman called Jacqueline B. In Paris, who falls into a coma for about a week and then recovers at the Hospital Pasteur for another 2 weeks before being released. Legret has some concerns about that, but the interesting thing is that during the phase 3 trials in West Africa and then during the subsequent mass vaccination program, it appears that none of these adverse effects are being observed. In fact, the researchers responsible for running the control tests to make sure that the vaccine is efficacious, to make sure that it's safe, report back no feverish or neurotropic effects, none whatsoever. So it seems like it's all fine, that whatever they were observing in clinical trials was not actually a big deal. Well, that turns out not to be the case as one digs deeper into the archives and looks at the actual reports that teams of vaccinators are sending back to the Pasteur Institute in Dakar. And there we see a picture of frustrated supervisors and difficult campaigns that reveal the thinness of African medical infrastructure, or rather French medical infrastructure in Africa, and the difficulty of actually conducting these campaigns. Vaccination sites were often located far from people's homes and required Africans to travel dozens of miles from their native villages to receive vaccination shots. Because the vaccine was administered via scarification, which is the method used for smallpox vaccination, many subjects did not realize that they were even being vaccinated against yellow fever and not against smallpox. And this is the critical part, few people wanted to return for controlled tests. One supervising doctor reports that Africans, having been vaccinated some days earlier, did not understand why they were being forced to travel again to get their medical checkups to see if they developed antibodies against yellow fever and so on. One Dr. Pelletier is writing frustratingly that Africans had a hard time understanding the reasons for control tests and spent little efforts in participating. So first of all, people who are being vaccinated do not come back to actually get checked up. The second problem is that the Pasteur Institute is pressed for time. They really do want to push through this campaign in 5 years. And as a result, they only have very little time, the teams of vaccinators, to spend in any one location. They usually leave within 8 to 10 days. But as previous tests in Tunis and in Paris showed, adverse consequences against the yellow fever vaccine usually took about 2 weeks to manifest themselves. So even if people vaccinated in Africa did develop some kind of adverse reaction, by the time they came back to report it, the Pasteur Institute's vaccinator teams would have already moved on. So I am vastly running out of time, so I want to draw this to a close here. But suffice to say that after the war, perhaps unsurprisingly, these adverse reactions started showing up again. In 1946, the United Nations Relief and Rehabilitation Administration tested the vaccine on 600 French soldiers who were told to stay away from military activity and to rest for a week after having received the vaccine. And even then, 12% of them had some sort of febrile or syphilitic reaction. One group, however, because of an error, went on a 15-kilometer march in open sun after being vaccinated, not unlike African subjects who had to travel to receive the vaccine during the war. And in that group, 1/3 of the soldiers developed some kind of adverse reaction. And the conclusion of the story really comes in the 1950s and 1960s when a number of cases are recorded in Lagos in British Nigeria, and then later in Senegal, where infants who've received the vaccine end up developing meningoencephalitis and dying. And we're talking about, in the order of hundreds of deaths here. And when Legret observes this shortly before his death, he sort of remarks with a certain amount of surprise that, I had seen these things before. I'd seen them in the 1930s during the development phase of the vaccine. But perhaps he should not have been so surprised because, as we've seen from the story of the vaccination programs, the thinness of the vaccinating infrastructure, of the public health infrastructure, the speed at which the vaccination campaign was conducted, and the general context of the war made it all the more likely for Africans to fall behind statistics. So I'm going to just halt here now and turn this over to Jess for her talk on public health in the 1940s, picking up where I left off.
Thank you so much, Aro. I already have all sorts of questions to think about here. So I'm also delighted to have the occasion to introduce Professor Pearson, who is Assistant Professor of European History at Macalester College in Minnesota. Her research explores the history of European decolonization from a global vantage point. In her first book, The Colonial Politics of Global Health, France and the United Nations in Postwar Africa, Dr. Pearson uses global public health as a lens to explore the clash between internationalism and imperialism in French Africa in the 1940s and 1950s. She is currently working on a new book project entitled Traveling to the End of Empire, Leisure Tourism in the Era of Decolonization, which will be a global exploration of tourism and European decolonization in the second half of the 20th century. She's conducted archival research in Aix-en-Provence, Dakar, London, Nantes, New York, Paris, and Washington, D.C. Her talk today is titled Libérté or Communauté, Public Health in France and Francophone Africa, From Empire to COVID. Thank you so much. I will pass the mic to you, Jess.
Okay, great. Thank you so much, Kathryn. And as Aro said, it's really great to be here today with such great friends and colleagues. Let's see. So I want to start off by saying a little bit about my experience in the pandemic so far, because I think it's really colored how I see a lot of the questions that I'm going to be engaging with today. And as Aro said, it's been really interesting as a scholar of public health history to watch the pandemic unfold. And I actually spent the first 5 months of COVID living in a region of the world that's totally unconnected to my research. So I was on sabbatical last year, and when COVID hit London, when COVID hit Europe, I was living in London doing some archival research in the British archives. On March 15th, in the middle of the night, I fled London with my spouse, who's Ecuadorian, and we headed to Quito, Ecuador, because we were on sabbatical. We didn't have a place to come home to in the United States. We arrived in Ecuador just hours before the border closed to both non-citizens and citizens alike, and that border stayed closed for 78 days. Ecuador was actually one of the only countries in the world that didn't let its own citizens back in unless they came in on a government-sponsored humanitarian flight. So the US news didn't really cover the pandemic measures that were being taken by the Ecuadorian government, but as far as I could tell, we were on one of the strictest lockdowns in the world. So while different pieces of the pandemic response in Ecuador were certainly politicized, what didn't seem to be politicized in quite the same way as it is here was the act of wearing a mask, or really the act of complying with any public health measure, for that matter. So in Quito, everyone wore masks everywhere they went. You have to wear a mask in your own car, or if you're, taking a stroll through a sparsely populated park. Government mandated temperature checks everywhere, including going in grocery stores. And for an extended period of time, only one family member was allowed to leave the house to shop for food. And they could only leave on 2 designated days per week. And for 10 weeks, we were under a curfew that started at 2 p.m. So it was really an enormous culture shock for me to come back to the States, where something as simple as mask wearing has become a hyper-politicized issue, the ultimate partisan act. And sometimes from my current vantage point, it can feel like resistance to public health measures has taken on a uniquely American valence. But I also know that from my own research that resistance to public health measures has an incredibly diverse and multifaceted history. And in many places in the world, this is tied to long entrenched histories of racism and colonialism, and that's what I'm going to focus on in my remarks this morning. So I want to take us back to French West Africa in the 1940s to think about this question of resistance to public health programs and institutions. And I'm actually really glad that Aro was able to show us some slides. I am more technologically challenged, so I'm just going to talk. So the questions that I want to think about are, when do people comply with public health measures and when do they push back? And what is that connection between public health, colonialism, and racism? The French began developing public health programs in France's West African territories at the beginning of the 20th century. These programs were focused on a long-term strategy of improving quality of life, but ultimately they were really about improving colonial productivity. The Indigenous Medical Assistance Program provided care to Africans free of charge, and mobile health teams provided care to people living in more remote rural areas. These programs concentrated on combating epidemic disease, which is something that Aro talked about in his presentation, but also about combating infant mortality and malnutrition. And these programs continue to expand throughout the 1920s and 1930s. World War II and its aftermath was a moment when many of these programs found themselves at a crossroads, both in terms of the practical constraints of providing health services during wartime, but also some ideological constraints. And today I want to focus on those ideological constraints, particularly the question, what can compliance with or resistance to public health measures look like in a colonial context? And what can they look like in a situation where the people involved have rights as citizens? So the reason that I'm so interested in the period that immediately follows the Second World War is that in 1946, the French Empire transforms itself and it becomes the French Union. And everyone living in the colonies becomes citizens of that union rather than imperial subjects. And that's going to have some really interesting implications for public health. So I want to start, though, with the slightly earlier colonial period, where the community that we're talking about is largely a community of colonial subjects before people gain these citizenship rights. So the health programs that were in place in these communities were closely linked to colonial racism. Many of these programs, especially those that focused on infant and maternal health, aim to displace the local authority of African women in favor of the more modern medical authority, modern in quotes, of white European men. French doctors in the colonies blamed African midwives for high rates of infant mortality, and they emphasized the role played by what they termed to be African superstition. In addition to perpetuating these stereotypes, European doctors also promoted the segregation of colonial cities in Africa, which they justified by arguing that a separation between the races was necessary to protect Europeans in the colonies from African diseases. And then also hospital wards and clinics were segregated as well. So if you looked at the blueprint of a hospital or a clinic, you would see that there was a European ward and a ward for African patients that was on the other side. So additionally, I want to point out here that there's a long history of unethical medical testing that was happening in the colonial context. And this wasn't really the specific focus of my research, but I do want to note it here. And if this is something that you're interested in learning more about, I would recommend reading, for example, Clifford Rosenberg's work on vaccine testing in interwar Algiers, or Guillaume Leschenel's work on the drug Lomidine, which was intended to treat sleeping sickness. So World War II, as I noted, is going to be a really critical turning point in this story. The war would have an enormous impact on public health in the colonies, both in terms of how French doctors were thinking, but also how these programs would be received by people living in the empire. During this period, doctors and administrators working in the empire embarked on a quest to completely overhaul the existing public health system in French West Africa. These medical reforms were in part about making a new place, a sanitary empire that would perfectly complement a reinvigorated post-war France. But they also aimed to create a new people, both literally and metaphorically, who would be able to populate this new and modernized empire. The expansion of healthcare in the post-war era would be about more than just physical bodies. It was also about political bodies. And as I mentioned earlier, after the war, Africans living in these colonies became citizens of the French Union. So for the first time, inhabitants of these territories, sort of across the board, possessed basically the same rights as people living in metropolitan France. Citizenship, as we know, involves more than just access to the ballot box. It also involves trying to generate a shared sense of belonging, shared values, and common goals, including in the field of public health. So the question that I really wanted to think about was, what was the effect of granting citizenship to Africans on the colonies on the healthcare system, and on how both French and Africans thought about both their rights and their responsibilities in the field of public health. For the French colonial administration, citizenship meant an increased obligation to participate in public health programs for the good of the community. By contrast, many Africans, especially women, saw this new citizenship status as a framework for rejecting public health provisions that they saw as coercive. When I was starting to do research for this project, one of the things that I was expecting to find were actually more demands for more healthcare and more social services. And instead, what I found was quite the opposite. So rather than using their newly acquired citizenship to make the case for more and better health services, Africans, as I just noted, used these rights to make a case for avoiding the programs and policies that they didn't see as lining up with their life or their experiences. So government statistics from France's West African territories show that until the Second World War, the number of Africans using French colonial health services was steadily growing with each passing year. And in 1946, that same year that citizenship rights were acquired, this trend comes to an abrupt halt. And the biggest drop that they saw actually occurred in the field of infant and maternal health services, where attendance plummeted in 1946 and 1947. Colonial officials believed that this drop could be attributed to a fundamental misunderstanding of what citizenship meant. One colonial health official in Ivory Coast, whose name was Revoix, wrote in his annual report, "The African woman, provoked by a few agitators of bad faith, believes herself free from all constraints, even those rigorously imposed by the law for the protection of public health, or other laws with the goal of ensuring the greater good." End quote. So African women, by contrast, claimed that as free citizens, they were no longer under any obligation to submit to control of their bodies by the French colonial government. Mobilizing the language of the Republic, women in one Ivorian village told local authorities that they were, quote, free, no more force, even for their own good. In another village, women told doctors that they'd gotten along just fine before the arrival of colonial medicine, and now that they were free, in other words, citizens, they could return to practices that were more in line with their own cultural traditions and with the realities of their lived experience. So Colonial health reports actually very rarely recorded the voices or the perspectives of their African patients. But I did find one extensive quote by a woman living in a coastal town in Cote d'Ivoire, where she was explaining to a colonial doctor why so many women in the town were reluctant to do extended stays in the maternity hospital before giving birth, and sort of what the change happens in 1946. And I think it's worth quoting in its entirety. She said to this colonial doctor, she said, "I hear your sales pitch. I know our daughters will be well cared for, watched over, and fed, but do not forget that for a woman, to give birth is a bit like going to war for a man. Just as he wonders whether or not he will return, she asks herself the same thing, whether or not she will lose her own life in giving it to another. In the face of the unknown, it is better for the birth to take place in her own home, where she is guaranteed the assistance of her family and her friends and the well wishes of her village." So, as African women mobilized their newly acquired political rights as a way to reject colonial health provisions, colonial doctors found themselves increasingly unable to resort to coercive measures for managing their colonial subjects, who are now citizens. And perhaps the most important shift was the sudden inability of colonial officials to employ force as a tactic for filling the maternity wards. And I just want to say that infant and maternal health was really a cornerstone of this project of encouraging a healthy and prolific African population. So, one medical inspector reported that in a clinic where he had once seen as many as 150 pregnant women assembled, all but 7 had deserted by the time of his last inspection. Another local health inspector in a neighboring village confirmed the political rationale behind this change in women's public health behavior. He wrote, "The drop in numbers of births taking place at maternity clinics can only be attributed to the evolution of contemporary politics, which are far from sympathetic to the regime of forced recruitment that we have employed until now." In addition to growing resistance to colonial maternity clinics and hospitals, Africans living in French West Africa also increasingly rejected French-sponsored vaccination campaigns. And in certain villages, some residents even resorted to hiding in the fields to escape the vaccination teams. So, as I was doing this research, I started wondering just how unique this rejection of public health measures was to France's African colonies, and how their actions might compare to their counterparts in the metropole. Interestingly, what I found was that despite health officials' attempts to cast African resistance as fundamentally un-French, the more that Africans began to opt out of health services, the more their actions actually began to mirror those of French citizens living in the Hexagon. One French physician named Robert Debré, who was really kind of the de Gaulle of the French medical world, noted in his lengthy memoir the frequency with which the French evaded public health measures in the name of their own personal liberty. And this is what he wrote: "The French care very little about public health. For them, health is a personal affair. It has been said many times, the French do not submit themselves easily to collective discipline. Each man thinks that regulations are made for others." I think this quote speaks to some of the interesting similarities between France and Africa around this notion of resisting public health in the name of citizenship and personal liberty. But at the same time, we need to remember that these stories of non-compliance with public health programs and protocols unfolded in radically different contexts. So what are the big takeaways of this story? And what does the story of resistance to colonial health programs in the 1940s have to do with the public health crisis that we're facing now? I think for me, the biggest takeaway is the need to keep in mind that even though from our vantage point here, where vaccine hesitancy and resistance to public health measures like mask mandates can seem like a uniquely American phenomenon, this is in fact a global issue. And even though we're living in a moment where we're seeing the US pull back from multilateral organizations like the World Health Organization, that doesn't mean that we should stop thinking globally about how to confront the COVID-19 pandemic and all of the pieces that this entails, including how to deal with deep-seated distrust of public health institutions and organizations. Resistance to public health measures, specifically vaccines, but other measures as well, is not actually a uniquely American phenomenon. And for many communities, both at home and abroad, distrust of public health institutions is linked to histories of racism, colonialism, and in some cases, highly unethical practices in the fields of health and medicine. In the US news, one of the things that I keep reading about is the shortage of African American volunteers for vaccine trials, which to me doesn't feel surprising given what I know about the history of medical experimentation on Black bodies in the US. And if this is something that you're interested in learning more about, I would really recommend Harriet Washington's book, Medical Apartheid. But really, this is a global phenomenon that we're talking about, and we're going to have to account for all of these complex and varied histories when we're trying to come up with a plan to vaccinate 7.8 billion people against the coronavirus. So there's a quote that I've read a few times in the news that I think really resonates with this conversation we're having, and I want to share it with you now. It's a quote by Daniel Salmon, who's the director of the Institute for Vaccine Safety at the Johns Hopkins Bloomberg School of Public Health. And this is Salmon's quote. He says, vaccines don't save lives. Vaccinations save lives. So if people are distrustful of vaccines and the institutions that administer them, then we're going to need to reckon with these intertwined histories of medicine, racism, and colonialism, and we're going to have to do it on a global scale. According to UN statistics, in 1945, 750 million people still lived under colonial rule. And today that number is about 2 million. But even in some of these places that did decolonize, there's still a collective memory of coercive and racist public health programs imposed by medical professionals who came from outside of those communities. So I don't know how many students are in the audience, but I just wanted to really say how critical I think it is for students of medicine and public health to also study the humanities for this reason, and to really think about the social, political, and historical context that these programs are being developed in. So I want to end my remarks about COVID and Africa by just raising 2 points about the current context that I think could potentially be interesting to pick up in the discussion. And the first is that I think when we're talking about COVID, one of the things that's been really interesting to watch is just how successful African nations have been at stopping the spread of the virus, and how much compliance there has been with life-saving public health measures that the rest of the world seems to be bent on resisting. And what I'm curious about is how much of this is coming out of the recent experience with the Ebola epidemic and how that might be shaping Africa's relative success in combating the coronavirus. And another piece I think that could be really interesting for us to unpack, and I'm curious to hear what you all think, is about why we're hearing so little about that success, especially when we heard so much about the failure of African governments during the Ebola epidemic. So just out of curiosity, I went back and I looked this morning, and since the semester started, there have only been 2 articles in the New York Times about COVID in Africa. One was about a religious festival in Senegal that's going to take place despite the pandemic, and the other was about the threat of famine in conjunction with COVID. So what I'm wondering is, why isn't there more news coverage of African successes, and why aren't we in the US and Europe and other places in the world doing more to learn from African successes? Do we still have a notion of Africa as a public health backwater waiting to be saved by white doctors that's just not clicking with the reality of this moment? Or is there something else going on? So I'm really excited to jump into our discussion, and I will stop there and just thank you again so much for the opportunity to come and speak with you all today. Thank you.
Much, Jess. Everybody hears, I can hear. It's funny, you actually sort of answered one of my first questions in your concluding remarks, because I did the same thing this morning to look at the discourse around African experiences in COVID. And I guess one thing that kind of surprised me was that the articles I did find, and some in French, some in English, kind of framed African success as a surprise. As in like, whoa, things are going so, surprisingly well there. What gives kind of frame? And that started me thinking about the colonial mindset of so much of the contemporary discourse about the global situation regarding COVID. I don't know, I don't necessarily have a full question here in the sense that you've already kind of covered a lot of that, but Aro, you noted in our introductory conversations that one of your primary thoughts in watching this all go down right now is that we've been here before. So I thought I might also launch into that to ask, what about our current situation either surprises you or else just makes you say, well, of course, we knew this already.
Yeah, thanks. Yeah, I think it is. I think one can be both like surprised and depressingly surprised, right? Like sometimes the surprising thing is like, why are we doing this again? And one of the things that really struck me is this problem of preparing for the wrong emergency, where I was just reading that book about the organizational crisis of COVID-19, and one of the things the authors note is that France, like many other countries, including the US, since around the early 2000s, has been developing extremely involved sort of scenarios for how to respond to public health emergencies. And France, like the US, keeps failing to actually implement them. So, it was in January of this year that the Pasteur Institute, developed its PCR tests, that it was theoretically possible to really scale up production, make sure that, every province in France was equipped with a testing capacity to test, trace, isolate, to stockpile PPE, to make sure that hospitals were properly equipped. And essentially nobody did that until late March. And by then, those options were effectively off the table because the epidemic had ballooned to such a size that you can't just recruit thousands of contract tracers overnight, right? You can't scale up testing overnight. This all takes time. So the only option left on the table was this complete lockdown. And that's sort of a similar situation that we saw in the US. And in many other places, with the notable exceptions of East Asian countries and Eastern European countries, and also Germany and Scandinavia. So I think that's one of the big sort of why this again questions. I don't know, Jess, what do you want to chip in here?
Yeah, I mean, a lot of what Aro said resonates with me. One thing that I'd be very interested in tracing, like the precise genealogy of, is places that have done a better job at dealing with the epidemic. I'm curious both about the role that sort of recent collective memory of a previous epidemic or pandemic plays in people's willingness to comply with public health measures. So I was thinking about like Taiwan and the SARS epidemic, for example, but I'm also wondering about like the infrastructure, like what infrastructure is translatable from the most recent epidemic to where we are now? Like what did West African states put in place for Ebola that they were actually able to use potentially to combat COVID? And then what adjustments had to be made? And I think this speaks to Aro's, point about, what is the disease that you're preparing for, right? That there actually are meaningful differences in how one combats different diseases, but there's also general infrastructure and a general mindset that I think is really interesting to unpack and to think about, like, what are the links between what happened with SARS and people's willingness to comply, but also just government infrastructure that was in place, and the same for Ebola in West Africa. So I'm interested in sort of tracing those. Macalester moved to a module system. So we're actually starting new classes next week, and I'm going to be teaching my public health in Africa class. And this is actually the precise question that I want my students to look at, is like, how does that transition from Ebola to COVID happen, and what advantages, if any, did that give African states?
Interesting. Thank you. And I'll ask just one more question before opening it up to the floor. I was thinking about, today, I don't know how much this enters exactly into your research, but what sorts of links are there between French and African medical systems within, independent countries now? And secondarily, not the same question, but a similar kind of angle, is how things are going in overseas departments of France, such as Martinique and Guadeloupe, where they are part of France and yet have this incredibly charged, historically colonial situation. So I realize that's sort of two questions in one, but how do colonial political structures end up implementing and determining certain relationships, medical relationships today?
Yeah, that's a really good question. I can maybe speak to the second question. I think Aro might be able to better speak to the first.
Thank you.
Yeah. So something that I'm actually very interested in, I don't know the answer to your question, but about the overseas departments. But I think that one thing that is potentially interesting is to think about the fact that many of those places depend on tourism for their local economy. To think about like what is the, what's the impact of stopping tourism when tourism inevitably is going to need to restart again, we can't shut down the economy forever. What is it going to mean if those people are coming to these like small island territories? That question got raised in Ecuador because Ecuador is also extremely dependent on tourism, especially from the United States. And actually right now, Ecuador is one of the only countries in the world that Americans are able to travel to. So actually, if you are looking to get away, you can go to Ecuador. You either have to bring a negative PCR test or you do have to quarantine. But they just couldn't, withstand the economic impact of having tourism continuing to be shut down. So I do wonder about places like Martinique and Guadeloupe that I imagine depend extensively on the tourism economies. So that's something I'm also interested in sort of picking up, but I don't have the answer for you yet.
Yeah, so I also can't really speak to the dom-toms, but I can speak to the relationship between France's research institutions and the ones in West Africa, and that's really a story that's impossible to tell without talking about the structural adjustment policies of the 1980s and 1990s, because after decolonization, a lot of these Pasteur institutes, for instance, there's a whole bunch of them in different places in West Africa. Those usually went to some kind of hybrid relationship where they remained formally a part of the Pasteur Institute in Paris, a kind of sister institute, but they, some of them also became partly state funded or, were somehow folded into the public health infrastructure of independent Africa, of independent African states. But then, of course, the thing that happens with the oil crisis of the 1970s and the debt crisis in Africa and the following structural adjustment policies is that all of that stuff gets pulled back and, privatized to a large extent. So these institutions really end up being super cash strapped in the 1990s, and they end up relying really heavily on grant funding from French institutions, from global development agencies, and therefore oftentimes end up being at odds with the actual primary public health needs of places like Senegal or Guinea, where Guillaume Lachenal has this fantastic story of a Pasteur Institute in Guinea that does this really lavish research project trying to find a new strain of the HI virus, and ends up basically not finding the virus, but making the claim that, in Cameroon, ends up making the claim that, okay, we've actually found sort of like simian zero of the monkey that gave the disease to humans in the 1950s. And this is, it gets a lot of favorable publicity to the researchers. Those are actually American researchers who are working on this project. But to what degree any of this is at all helpful for Cameroon's public health is highly debatable. So that kind of challenge where there's a disconnect between these research institutes that are linked into sort of Western networks of status and prestige and the actual health needs on the ground is a real one.
Thank you. So I would imagine we have some questions from attendees. Just to clarify, feel free to either raise your hand in the participant box, or if you'd prefer to feed the question through the Q&A on WebEx, that's also fine. But I'm happy to take some questions from the floor. And if people are still figuring out the technology, I'm just checking to see if we have any hand. Okay, I think I just raised my hand, so I'm going to lower it. So I guess as people figure out technology, okay, I think we have a question from Avery. Was Avery League? Did you put your hand up?
I did. Can you guys hear me?
Yes.
Okay,
Perfect.
perfect. Yeah, I had a question about, so my question was about West African immigrants living in France today. Do you think that this history of racism and public health in Africa and colonialism in Africa, do you think that all of these things have any impact on the relationship of West African immigrants with the French health system when they are living in France itself?
I'll start. That's such a fascinating question. And I don't know the answer. But I'm thinking about like just even observations that I've made in my own community here in the United States. So Minnesota has a really large Somali population, and just even as I walk around the neighborhood, I see like where people are embracing or not embracing some of the public health measures, especially mask wearing. And I've definitely noticed that I see a lot more. I'm seeing a lot more mask wearing in the communities with larger migrant populations, and I've been trying to sort of think through like what is that because I'm not sure. I'm actually not sure the reason behind it, but I'm sort of trying to think about like, would that also translate to France? I know your questions about distrust of the medical system or confidence in the medical system, and I'm actually not sure about that. Aro, what do you think?
I kind of want to take a different angle to this question and kind of highlight the issue of differential access to infrastructure and the different kinds of structural conditions in which people live. And there, I think the disparities are well documented and huge, right? And generally, not just in the case of West African immigrants, but in the case of all kinds of marginalized populations. Like in the US, we know that Black and brown communities have been hit disproportionately badly by COVID-19. And if you sort of think about this for a moment, it makes an infinite amount of sense, right? So for one, we're talking about populations who often work in sectors that are considered, ironically mission critical today, where you can't just work from home. The supermarkets need to be stocked. People need to be cared for, right? A lot of times, immigrants work in various care industries as nurses, as social workers, etc., and also live because of historical reasons on in places that are much more crowded with a lot more people per square footage, right? And these are all things that correlate highly with the spread of COVID-19. So I would imagine that this is pretty much the case in the case of the West African population in France as much as it is, with let's say the Mexican or Latino community in Los Angeles.
Yeah, and I wonder also, just to piggyback on Aro's comment, one of the things that I think we think a lot about in French history is what is the impact of the French government not keeping statistics on race? And I do wonder, like, I have seen a lot of really interesting maps of the United States and a lot of statistics about the disproportionate impact of COVID-19 on Indigenous communities, on Latinx communities, on Black communities. And I'm wondering sort of what would it mean in the French case not to have that data? And I know often income is used as a proxy for race or immigration status, things like that, in terms of government statistics. And so I do wonder how much French government statistics are fully capturing that disproportionate impact.
That's a really interesting question. And actually, it reminds me of an anecdote just quickly. Avery, it's been a long time, but about 10 years ago when I was doing research in France and I had to go through the immigration process. I don't know if, Jess, you've had to do this, where you go and get your tuberculosis x-ray as part of the visa green card, visa carte de séjour process. I remember in 2010, or I guess in 2009 when I did this, there had been a lot of debates about full body coverings. And so this was more geared, I think, toward the North African population. But because I was, tracked into the women x-ray line, you go into the private room to get changed, to get your x-ray done. And there was this incredible poster. And it was about kind of national identity integration, but about like women, please note, you are not obligated to wear these full body veils, but it was done in such a way that I think now we would articulate in terms of microaggressions. And I was so shocked by it that I took a picture at the time, but it's been 10 years. And I just thought, I was just thinking about how much distrust in the medical system a sign like that could provoke, because it was so incredibly violent in so many ways that I thought, if you're an immigrant coming in and discovering France through this administrative bureaucratic procedure, and the first thing you see is this basic rejection of many, just things you subscribe to, I just thought, man, this is terrible. It's so incredibly violent. But anyway, it's just an anecdote that I thought of in response to your question.
That's so interesting, Kathryn. I also did this in 2009, and while I did not see that poster, I did notice that the people around me that were coming from places that were not the United States were being sort of subjected to a wider battery of tests that involved like blood draws, things like that. So like I went in for the tuberculosis x-ray, but I noticed that other people were getting like additional screening. And that struck me as very interesting also.
Other questions from the floor? And I guess while people think, I mean, this is just a question I thought of as you were speaking, but I don't necessarily need to jump in over other people, but so please feel free to think about raising your hand. I was interested in your experiences in the archives, kind of more in the practice of history, and in particular, where one goes to do these types of research. I can see how it can fit into so many different types of archives in different locations, and also raises so many questions about who gets archived and who doesn't. This touches on just so many sensitive questions about the practice of history. So I thought maybe that would be something interesting to talk about from a kind of methodological perspective.
That's a really interesting question, and I'm sure actually that Aro and I went to many of the same archives, some of which were very lovely places to work, some of which were less lovely places to work. I'll say that like there's all kinds of places that you can go to consult these materials. Most of the doctors that I focused on, and I think it was probably the same for Aro's case, were military doctors. So, I found things in the French colonial archives in Aix. I found things in the archives of what was the Institute of Tropical Medicine of the Army Health Services, which when I consulted them were in Marseille, and now they've moved to Toulon. Who doesn't get archived, I think, might be an even more important question. What I shared today was actually the only slice of my book where I was able to find African voices responding to like how they found what was their experience encountering French colonial medicine. And I think this is the biggest critique of my book, and I would make this critique myself. I found it incredibly difficult to really draw out African perspectives, because you just don't find those in the archives from this time period. And I think that was sort of a motivation for thinking about my second book, which is going to cover the period from 1945 to today. And I think part of it was that I sort of felt that like lack of African voices, and that's something that I really want to try to include in my next project. Aro, what was your experience?
Yeah, the whole experience of researching this book was really one of the things that made me think about how data and statistics are manufactured, and who gets included in these high level official reports, and these kind of aggregations of information that end up being the basis for producing something that says, look, we vaccinated 14 million people in these various regions of West Africa. Here's what we found, right? Because the most interesting places for me were, I worked a lot in French archives at the Institut Pasteur archives in Paris, in Colonial archives in Aix, and the same archives I worked in Toulon and in Marseille. They'd moved by the time I got there. But the most interesting stuff, for instance, I found in the Pasteur Institute archives of Dakar, where like literally we had to, me and the guy who was the head librarian had to crowbar open this like door to a shed on the roof of the building because it had been like so long since anybody had opened it. And that's where you find the really like the kind of primary sources of these vaccinator teams going out to the far reaches of Senegal and reporting back, and that's also where I had the similar problem as Jess. The really difficulty finding African voices. It was a little bit easier working on Senegal because African elites, Africans in Dakar had voting rights, so they had a kind of lively civil society. There's more sort of written word left behind, but it's in those documents that you really found vaccinator teams saying, look, like we went to this village, the chief of the village was like, why are you even here? We had smallpox vaccinators come through last month. Why do our people have to go on another 12-kilometer hike a week from now? Nobody wants to do this. Like, this is all crazy. Or you might have a very different and very friendly response, right? But but none of that stuff really floated up, right? Because you don't want to report back that, we don't even know if these guys ultimately showed up. You want to report back a success story.
Thank you. So I know that Diana Barger has had her hand up for a little bit. So if Matt, you could unmute her, and then after that, Hillary Silver has asked to also ask a question.
Hi, can you hear me?
Mm-hmm.
Hi, so my name is Diana Barger. I'm actually a postdoctoral researcher in public health working at the University of Bordeaux. But as you can hear from my accent, I'm actually originally from the US. So I was really, I just wanted to thank you for your presentations and especially for doing this research in the first place. I had two things. I had one thing to add just in terms of how you measure, ethnicity when you don't collect race in France. Often people talk about being born outside of France. That's some of the kind of things that we try and do in social epidemiology. But I totally agree with you with the fact that, you're seeing all this disaggregated data by race in the US. And I think that's a little bit, there was a bit of lag when we started seeing that data in France related to COVID. And then I had a question for the two speakers, which was, have you presented this research in France, and have you come up against and have you been challenged at all in terms of the perspective and just the reception by the French establishment? Thank you.
Thanks for that question, and actually thank you a lot for the just the additional information about the collecting of statistics in France. I find myself at the stage of my career weirdly unconnected with, I think, like the sort of parallel scholarly community that's in France. I feel like I have some. Most of my scholarly networks are abroad, are like in the UK or Portugal or Germany now or Switzerland. And I've actually very strangely and sort of embarrassed to admit, I have not presented this work in France. I would say that the most sort of pushback I've gotten has been when I presented this at African studies conferences and associations. I really trained as a French historian, and I think I've tried to like make some brief forays into like learning more about what the African perspective could be, or tried to situate myself in that literature. But I think this connects back to Kathryn's question about the archives. I just had such a hard time finding some of those voices, and because I didn't have any training in oral history, and I really did this as like a kind of strictly archival project, and I was using government archives. I think that's where I've gotten the most pushback. I would be really interested to present this in France and to see what the responses. I don't know what Aro's experience has been.
Well, my book came out literally pretty much the same week as lockdown happened. So I had a bunch of talks lined up for early 2021 in France, but I don't think those are happening. But I was in on a couple of fellowships in France when I was working on the book manuscript and before when it was a dissertation. And I found the reception to be, really, critical in a positive sense, and both critical of the work, but also critical of the French historical experience. But I think that's also partly a function of the audiences that I was presenting to, which was largely anthropologists, historical sociologists. I stayed at the Centre de Sociologie de l'Innovation at Mines Paris Tech, which is where Bruno Latour used to be. So you kind of get the sense that those are not going to be the guys who are going to be, playing up France's civilizing mission or anything like that. I've talked to Guillaume Lachenal about the book, and obviously he is the last person to play up France's colonial history in any way. So in my sense, that the response has been pretty much as good and as appreciative as it's been in the United States. But I imagine that in certain other venues, it might be different. And I've certainly in the archives and just generally talking about it to people I've met in France, heard a very different sort of initial reaction than I have at places like the CSI.
Thank you. And I think we have time for just one last question. Hillary, I will send it over to you.
Can you hear me? Can you
Yes.
hear me? Oh, great. Okay. I'm on my cell phone, that's why. First of all, thank you very much and congratulations on your books. They're really, this has been very enlightening for me, things I'm not familiar with, but I did encounter a bit of this when I was living in India and I was working at the French Cultural Center. And there were a lot of French epidemiologists who are working on dengue. And it seems to me that this tradition continues, it persists, even now, and even in non-colonial countries. And I was wondering if you could say a little bit about, you looked at the Pasteur Institute, and of course, this is not just a colonial institution, it's also a scientific one, and therefore, really dealing with some of these epidemics that are truly global, so that the colonial ties may be less important than the scientific ones. And I was just wondering if you could say a few things about that kind of French networks in public health epidemiology and so on.
Yeah, it's. I'd say the answer is sort of both, right? You're right. It is a global network, right? There's a Pasteur Institute in Shanghai. There are a couple of them in India. There was one in Constantinople / Istanbul. But if you look at how the Pasteurians themselves talk about it, then they are very much aware of themselves as being agents of empire. And there is a kind of privilege they accord to their colonial institutions that they don't accord quite to these others. And there's a good reason for that, which is that they get a lot of resources by being friendly with various governments general. They get a lot of support. They get a lot of funding. They get a lot of manpower. They get a lot of it's a place where they can run experiments with a friendly administration and very few other competing institutions on the ground who can be a pain in their butts. And to speak to the present day kind of continuation of these networks, then sort of interestingly, that's there's a huge debate. If you look at what's happening in places like Indochina in the 1920s and 30s, there's a huge debate over whether this kind of Pasteurian focus on vaccinations and these techno fixes is the right way to go. Actually, there are a lot of Vietnamese doctors who say, look, actually, what about shorter working hours, better nutrition, sanatoria, all of this stuff that you guys are building in France? Why can't we have this stuff? And basically the Pasteurians respond, shut up, you have the BCG vaccine, that's good enough for you. And now, ironically, very often when new sort of global health projects are proposed in Africa, for instance, then very often the argumentation is, look, the Pastorians did it so well. Look at those vaccination campaigns from the 1940s, right? We have that infrastructure there. We have those institutions there. We have the know-how. And, you know, of course, like that, those are not like, those are success stories by only like some very, very limited metrics. They're certainly, you know, and very often they were used as excuses to avoid sort of broad-based infrastructure or development. So it's kind of ironic to see how now they're being used as yet again as an excuse to focus on that rather than actually sort of building out primary care infrastructure and stuff like that. So it is super fascinating, and this definitely, you know, casts a long shadow over global health today.
And I would just add to Aro's point, this isn't specifically about the Pasteur Institute, but I think that there are these connections between France and the colonies in terms of, you know, medicine and scientific research, but there's also this sort of impulse to, I don't really know any other way to phrase this, but I'll say like make French medicine great again on a global scale. And one of the organizations that I worked on is called the International Children's Center. And basically the only thing that distinguished this organization from UNICEF was that it was run by France as opposed to the UN. And it was actually half funded by UNICEF. But the idea was that like UNICEF was great, but the French could do it better. And this organization existed until the 1990s. So I think that you see this in other places, not just the Pasteur Institute, but this idea that like French doctors and French medicine have something to offer the world that like can't be gotten elsewhere, that there's like a specific French brand of medicine and science that can really benefit the world, and that can be a way for France to shore up its own global position.
That's a very interesting note to conclude on, actually. I think this sends us off into the world with a lot of interesting ideas on what to look for in contemporary French discourse. So I just wanted to conclude by thanking our panelists, Jess Pearson and Aro Velmet, as well as our participants, and specifically a note of thanks to GW and the Institute for European, Russian, and Eurasian Studies, which has been our kind of intellectual and administrative home for this series. Matthew Cooley's been on the call this whole time facilitating our technological side. There is a recording available that will be on our website and I believe on the Facebook page as well. So again, thank you to everyone for your participation, and vive la francophonie, as Aro says.
As I said, ironically.
Indeed.
Thank you so much, everyone.